All right, so this is just pretty straightforward in terms of us just communicating to you all what our PCORI grant is. I know most of you have heard about it at this point, and you've heard little tidbits here and there, but don't really know the gist of it. So hopefully after today, it's something that will be a bit demystified. So it's called Trauma Resilient Research Co-Production to End the HIV Epidemic in the Southern U.S. We're going to just quickly go over some background of why we felt this topic was important and what drove us to really write this grant and to get it funded. And then we'll break into talking about the aims and the products we're looking to create and really what the reach of the project will be. Give you some examples of where we've started and what it's looking like, and then kind of like what our next steps are. Some of the guiding considerations or questions that led us to really think through this project were really, what is a research beneficiary? Who benefits from research? I mean, these are kind of existential questions I think we all have at different times as researchers. So really thinking about, you know, how people benefit from it, maybe how they don't, how people do and don't hear about it, the people we want to benefit from it, and we maybe never really fully get there, or we want to have a greater reach. We also know that sort of a concept in the backdrop here is implementation science, and really that it's driven us to know that we need to adapt different practices to different settings, and we know that to do that, we actually have to rely on relationship building and sustaining relationships, and so that really led us into thinking about if the community is actually benefiting in the same ways that we are as academicians, and what it takes to really like what's the science of how we build those relationships and what's the science of how we keep those relationships. And yeah, so and that also led us to really just thinking about what research quality is. So who determines if something is of quality, is of good quality? And more often than not, I think we've been bound by the same systems of a peer review process, and it really hasn't been the actual research beneficiaries themselves that have been asked to determine if something is of good quality. And then even, when that has happened, I don't think that it's been something that we've celebrated enough as a new metric for rigor. So yeah, that's really what led us to the current project. And now I'm going to pass it to Amna for a few slides.
Thanks, Lauren. And so as we started really thinking about the federal funding for HIV as it continues to grow and really looking at trying to end the HIV epidemic by 2030, we started asking ourselves, there's so much money that is being put into HIV research, but very little funds or very little engagement of community has been put into the research that we've seen. And in order for us to really be able to move the needle in ending the HIV epidemic, we need to really make sure that community is part of the research from the inception all the way down to the dissemination. And there has been a big call from the UN member states, from the WHO, from HRSA, that it is really critical and important that community is part of research, and research is led by community and by the researchers in order for it to be effective and for us to really understand the hard to reach populations that are disproportionately affected. And so it's really important if we're really going to address all of the health outcomes that we want to see in ending the HIV epidemic. Next slide, Lauren, please. So as we think about community-led research, there's very limited literature. We looked at the literature, and there was a systemic review done in 2021 of community-led research. And what we really found is, in order for us to think about what's in the literature, there was a lot of gaps. Community-led research is in its infancy phase. There's only 9 randomized controlled trials that were reported in the last 40 years. And so we really had to stop and really pause that, wow, with having an epidemic that's been around for over 40 years, we are seeing very, very minimal community engagement in research. And really, when we talk about community engagement, we're talking about co-production. How can we have community being part of research and co-producing it from the very beginning. And so that's really what really led us to think about this PCORI project and really looking at trauma models and also co-production models and blending them together if we're going to be able to really move the needle in ending the HIV epidemic in the South. And so we looked at what I call this continuum of HIV research. And so you can see we had to really pause. And it was very interesting and eye-opening for us. That is, if we look at just as we're formulating research questions, very few studies and very low percentages of community are engaged in just really even formulating what is the research question? What are we trying to study? What are we trying to understand about a community or a subpopulation? And really engaging a community from the inception. And as we look at moving forward in protocol, that percentage starts to kind of increase in recruitment. So when I sit back and think as a community, organization and a community participant in research, I really see that researchers engage us a lot in the protocol and the recruitment. But as we start to look at enrollment, we start to see a decline there in the follow-up. And the biggest that issues that we see is in the results that are being put together of the research projects and studies, and then also in the dissemination. And of course, after that publication happens, where we don't see co-authors from the community being part also of the publication and any follow-up after the study is completed. So we really had to look at this and pause to really think about, in our project, how are we going to engage community from the inception throughout the whole process? And how are we going to also have them be part of the solutions and follow-up studies and subsequent studies that need to happen after a project or a research study is initiated and completed? So one of the big things that we felt that community-led responses plus the structural level of interventions, where can we get the greatest effect? And so connected to these outcomes is we needed to really look at improved HIV-related knowledge. We really needed to think about the attitudes and intentions that were happening, the self-efficacy and also the health literacy of what was going on in order to be able to have these outcomes. Adherence and viral suppression is really critical, and really looking at the service access and linkage, making sure that utilization was peak and also retention, and really the quality of the care that was happening. So looking at all of these connected to these outcomes, it was really critical for us to say, as we develop this project, we need to create dyads of community and researchers if we're going to be able to be successful in really looking at health outcomes related to HIV. And so some of the strategies that really might work and that we want to test is that bi-directional power sharing. It's about different methods that we actually engage in really trying to understand what is going on with communities, and also making sure that we are inclusive and really, collecting those personal stories, looking at different ways to be able to share what's happening in the community, and really having community folks that are innovative and creative and understand how to really tell the stories of what truly is happening in a community or in a group of folks that really we need to understand and study and understand what are some of the outcomes and what are some of the patterns, barriers that are going on and gaps in community. And it's also that kind of really being able to allow researchers to allow community folks to be able to really have their voice heard and that their voice matters in what is going on. And then the crowdsourcing is really looking at developing group solutions and really being able to look at the principles of community-based participatory research and looking at research from the bottom up versus the, from the top down. And then really being clear and intentional about communication. This takes a lot of work, and it's really not something that we just kind of create and just think that it's going to work. You have to put really some critical time and effort in it. And one of the things I appreciate about my relationship with Lauren, since I got to know her when I came to CARES, is that her and I really had to develop this relationship, from the power sharing, from really having very clear and intentional communication and honest communication, and also knowing that we have a mutual benefit of what we're trying to do to really support communities, and that we have the shared decision making, and that it's equitable, and that our roles and expectations are very clear and defined, and that we also learn from each other. It's this, peer-to-peer learning and really growing. And just as we built our relationship to getting to the point of actually getting this PCORI grant, it has been really valuable in learning from each other and growing. And what we've put together is extremely powerful and very strong, and I think will really help us truly have an impact on what we're trying to do in the 8 states that we're trying to work on through this study. And then just really thinking about the partnership and really creating a human-centered design. All of these studies are studies that are impacting people and people's lives. And so it's really important. And one of the most important things that we've seen in taking the trauma-informed models is this trauma-resilient approach, that making sure we're creating a trusting environment, a safe environment, a nurturing environment, and an environment that when we think about community-led research, what is the give and the get that the community is getting, and also the researcher, and ultimately, as we think of whatever community or jurisdiction that we're impacting. And so gaps to be addressed, there's been a primary focus on prevention, lessons learned, case studies, or single sites. So really through this project, we're looking at 8 sites across the United States and really looking at all populations and high-risk populations, or what we call difficult to reach groups. We also are looking at the effectiveness of the project delivery. So we're really looking at ways of making it effective and having conversations at the very beginning of research. And the relevant outcomes really need to be communicated to our beneficiaries. So we need to use terms and jargon that they can understand and really breaking it down for them. Also looking at the partnerships that we can see, so not only from the research studies that we're conducting, but where can we bring funding and new opportunities to really enhance the larger system and the infrastructure of community-based organizations and institutions to really be able to do the work. And then this give-get of the mutual benefit between science and community. And then really, ultimately, the bigger and the macro goal is how do we look at changes in public health outcomes so we can really reduce the incidence of HIV as we move along. And so now we look at this continuum of care. We just really wanted to outline it here for you. So we have the equity indicators and the contextual factors. And if we start to really look at this and where we really see the strength of community-based research, it is in the continuum where we have transparency, we have mutual benefit, we have resource sharing. The decision-making is one that is mutual, and the ownership, really critical and important. The ownership is a shared ownership, and that we have balanced power and control. And as we look at that, we can really see that we're building the trust, we're building the building blocks for success, and we really have a very transparent study and project. And this is what our hope is as we go into this project, that we will be able to really build a continuum of community-engaged research that everyone benefits from, everybody engages in, and everybody learns from. And I will turn it back to you, Lauren.
Thank you, Amna. Let's see, I can't say myself, so I want to make sure I came back on. Okay. Yeah, so thank you very much for, I'm going to try to raise my computer up here. I don't have it on a table. Thank you very much for the background of that. That brings me to really talking about a concept that was at one point, maybe last year, new to me, the concept of engagement science. So I like to think of this as just kind of tucked within implementation science. I'm sure some people might disagree with that, but it's specifically just, as I mentioned earlier, studying how people engage, what allows them to build relationships, what allows people to build trust. But generally speaking, engagement science is defined as just bringing non-professional researchers into the scientific investigation process. And importantly, as members of research teams so that they're sharing in all the phases of the process. So in framing the question, collecting the data, interpreting the results, and disseminating the conclusions. Um, so I think it depends on what part of the world you're in and what type of science you're in, but we generally are referring to this as co-production. And some people might say, oh, well, this is more like CBPR, community-based participatory research, or, we try to say that a lot of them are very similar in like 97, 98% of their DNA, and to not really split hairs over what nomenclature you're using. But what's most important is that it really just, in its true essence, is engaging non-professionals, non-professional researchers in all phases, and that's the operative piece. It's not just quote community in the sense that it's not just patients or clients with lived experience, but it's also people with lived experience working in these spaces and working on policies related to these spaces. So really just celebrating and bringing in everyone who is part of contributing to what makes the continuum of care actually possible. So the intent is to bridge the gap between researchers and people practices of study, and the ultimate benefits are really to improve the quality, to heighten our impact, enhance the how people view the esteem of the science, so that it's not just something that's shared with the scientific community or sitting in a paper, but it's something they can actually see as tangible and understand it. And that it's really all of this together is helping us really address real world problems. Ultimately, we hope that the outcomes are that our research protocols are more acceptable, they're more feasible, that they actually are things that we can share, within the community outside of just the scientific community in a way that is understandable. One second. Okay, so um, this is just really showing, going back to one of the slides that Amna talked about, like that we want it to be a 30%. According to the UN and HRSA and WHO, we really want ideally 30% of community or of HIV research to be community led. So this is what we're looking for here. And I just ballparked the 30%. And I'm sure someone with a more, um, you know, a brain more around aesthetics might disagree with that percentage, but that was a ballpark. And this is really where I think we are, if even this, maybe not even that much. So just, kind of going back and forth here, it shows how much work we have to do. This is just showing where our current project is for this PCORI grant. This is only 7 of the sites because we do have one that's open, and I'll talk about that in a minute. But these are the cities and the states that they're in. So obviously we're focused on the South because these are the priority jurisdictions that we're interested in. So going into just kind of an overview, most of you obviously know who Amna and I are. So I'm as the Meharry representative and Amna as the Nashville Cares representative. Again, our focus is obviously on the U.S. South for the EHE priority jurisdictions. And it's a 3-year project. We just got started for year 1. And PCORI, if you all have never worked within their system, they have like a mandatory 6-month dissemination process at the end, which I actually really appreciate. And this is our core team. Obviously, Amna and I are as the MPIs. Rob McLean is really a third PI. PCORI will only let us have 2 PIs. I'm actually petitioning within their system to try and change that because Rob was such a critical member of, it's really his idea to do this grant, brought it to us, and it's really Research Quality Plus for co-production is a model he created with his team. And the concept of this is really to sort of integrate that with the organizational trauma resilience framework so that we ultimately create trauma-informed research approaches, so that we ask research beneficiaries to rate if the system itself and the research process was transparent, was safe, was collaborative, all these things that you see in trauma-informed care. And ultimately, that's how we gauge if it was of good quality, or one of the mechanisms. And so then you have our other co-Is at University of Louisville, UAB, also in Ottawa, and then at VUMC, and Jamie Stewart as our program manager. Ultimately, these are kind of shifting a little bit here and there, but so we have 8 total dyads in this network, And again, each dyad is made up of an academic partner and a community partner. And so not only are Amna and I MPI, but we're also representative of one of the dyads. So we have our own kind of experiential engagement with this. And our project will focus on Nashville Care's mobile clinic. And so you can see the second column here. Every project is focused on something different, and that's on purpose, because we really are interested in, across heterogeneous kind of settings and populations and things like that. We want to really understand broad strokes of how engagement is working. And so, yeah, so we have us, and then we have University of Louisville, which is responsible for the entire state of Kentucky. Then we have at Ponce in Atlanta, which I believe is the biggest AIDS service organization in the South, maybe in the country. Amna and I visited over the summer and we're just blown away. It's like 7 stories just devoted to HIV care. Then we have UAB, which is the academic partner, but Five Horizons is the community-based organization. From what I understand, it's really similar to Nashville Cares. And I'm actually in Birmingham right now because tomorrow is our first site visit here. And so very excited to see that for myself. Their main campus for Five Horizons is actually in Tuscaloosa, but they also have locations, I believe, in Birmingham, a couple other places, as well as in Mississippi. Um, and then we also have South Carolina, and then we have a Wash U group, which I don't know exactly what their focus is yet because they have several different CBOs that they're choosing between. And then University of Miami with the Positive Peoples Network. And then finally, we have a dyad that just finally fell through like maybe 2 weeks ago. So we're trying to figure out who our final dyad's going to be. We've talked about maybe Memphis because we all know that it's such a priority and there's less resources there. But, obviously one of the issues with less resources is that it's not easy to find devoted partners to do this work there. So if you can think of anywhere in the South, that might be a good partnership or a good location, certainly let us know. And we're going to keep trying to figure out if Memphis might be a good fit somehow. Ultimately, the goals of this project, there's really 3 aims. So in the first year, in the first aim, we wanted to build this network of dyadic partners. So there's 16 of us representing 8 locations, 8 regions. And together in the first year, we're really just going to explore to try to define what some enablers and constraints of research co-production, trauma-informed research co-production are out there in the world. So it's really just trying to understand it. And we're going to do this through an iterative process, which is kind of in the beginning, a little bit of focus groups. And then from there, we're going to generate, we have most of a survey generated, but we'll use the focus groups to really fill in some gaps and reinforce some things. And then after that, we'll do focus groups again to really just get a rich understanding of what we found in the surveys. The second year is a really deep dive just at Nashville Cares, where we start to really look at this as a model. Like now that we understand the enablers and constrainers, really understanding what we might need to make enhancements in so that we can start to develop a model of how to create this science of engagement. And looking at it as an instrument that where we can actually measure these things, and then really start to try out through PDSA cycles some strategies, and start to do some preliminary effectiveness testing of how these strategies do or don't enhance engagement. Ultimately, from there in the final year, we hope to scale some of those strategies and really start to estimate the impact across the priority jurisdictions. So as I mentioned earlier, we have the 2 different frameworks that we're integrating to develop this trauma-informed co-production model. So we have the Organizational Trauma Resilience Assessment, which our team developed, and then we have the Research Quality Plus for Co-Production model, which was developed out of Ottawa. But really tested mostly in the global South. So it's really bringing in things. It's kind of the reverse of a lot of research that's happening, rather than things happening in Western North America and then kind of transplanted into other places. It's really taking things from throughout the world and bringing them to us, things that have been more known for kind of community kind of engaged processes for a while. And then you can see, obviously, we don't have time to go into each of these, but you can see that when I talk about here on the left, the Research Quality Plus for Co-Production model, it's really redefining what rigor is. That rigor is not just a positivistic concept, that it's about like group decision making and how we elevated different voices to collectively decide on what would be done, that is actually seen as a place of rigor. And through that, we build that through, um, you know, grounding this in local realities and context and knowledge so that it is actually mutually beneficial. And then, of course, we have to have attention to trusting partnerships and intersectionality and really talk through attention to potential negative consequences. Ultimately, all this will, we hope, set it up so that this is positioned for use rather than science that is more difficult to translate back into practical use. And then on the right, you see the organizational trauma resilience dimensions. These have been tested with personnel and more recently with patients, specifically with HIV. And now, even more recently, with caregivers and pediatric intensive care units. And it's just continuing to grow and evolve. Also, a study with SAMHSA, with community-based mental health organizations. But generally speaking, this is becoming more of a gold standard of how we measure if an institution is safe, stable, and nurturing. And so we hope to take these concepts and really weave them into the practices of research so that we can start to measure if research is safe, stable, and nurturing as a process to engage with. And this is just really explaining the concept of co-production, as I mentioned earlier, making sure that it is a dynamic process that's not just like one-time engagement and then, with a community and then we take it and run with it from there, but really seen as something that we're doing before, during, and after. So throughout the breadth of the process. Ultimately, as I mentioned, we hope to create the actual approach, a model, an instrument, and hopefully a toolkit so that, and not like a one-dimensional toolkit that sits in a PDF, but something that people can actually really engage with and understand through various mediums and ways that have been packaged to really reach lay communities and be understandable. And so ultimately, as a network, we've set this up so that even this project is being co-produced by this network. Hopefully, we are striking a balance between academic and community partners. And so, basically, we will meet bi-monthly as a virtual group, and then Anna and I will meet with each of the dyadic partners individually monthly for technical support. And, she and I will really drive the process, but then we'll come together once a year in person to have charrettes, which is where we'll really review all the findings, develop, talk about what it means, um, and then talk about what the next phase is, what we're going to do with this information so that it continues to be data driven. So you can see, this is a little in the weeds, but I wanted you all to just see the real volume of data that's being collected here. That, it's a lot of focus groups. It's really only 2 with patients and 2 with personnel in each site. So it's not, I hope, not very onerous for each partner and each location, but ultimately it's going to really give us a good understanding, I hope, of just what this science of engagement is looking like in the beginning in year 1 currently. What's the standard? What's the standard of how people are or are not doing participatory research? And then, as we keep going, we're hoping that we can start to see even things like geospatial mapping, starting to map out where participatory research is happening, particularly in these priority regions. So I think there's a lot of potential here for us to do some novel things of really just kind of moving the needle on, at the very least, sites that aren't even participating in this, just thinking about being part of a community who are wanting to do participatory HIV research and really elevating the prestige of this concept so that ultimately, hopefully we've created a model that people want to use and they find helpful. These are just some of the scientific products. So you can see it's a lot that can come out of this, a lot of metasyntheses every year of each kind of stage of this research and piece of this research, but then also individual products where we can kind of dig in each of the locations to tell a deeper, more specific story. For example, you can see in year one, some places are like, for example, at Ponce, they're just going to focus on Black cisgender women. And so I think there's been a lot of chatter about how we haven't really done enough of that in the movement. And so this is going to allow us to really dig into different populations and really start to tell the story of how different groups of folks are engaging in a different way. So we'll get a snapshot of overall what the science looks like, and then we can start to tell the story of different populations. Also, it may be that there's another one that just looks at cisgender Black women with PrEP versus people living with HIV. Really how this looks in a mobile unit, how this looks in a status neutral setting, things like that. And so to do this, we started to really just gather some preliminary um, data before we got started so that we could just hit the ground running in January. And so we've already collected a decent amount of data in some other studies that we've been working on to try and start going, how do we ask these questions? In all the ways that these seem like no-brainer ideas, they're not really easy to come up with ways to ask so that we're not asking jargony questions. So I'm going to show you kind of what that looks like. So this is from the AIDS impact abstract we just submitted with a data set, a quantitative data set of 218 cases. And we found, and these I think really, to be honest with you, I think are a bit inflated because for two reasons. One, potentially how we originally asked the questions. I'm not sure that I think that they're all totally believable in the responses. And then on top of that, how we dichotomize for the purpose of just explaining this today. But generally, we went with anything that wasn't a no or not at all as a yes. So there are gradations in there of a little bit all the way through totally. And so when we asked if this topic was important to them, and again, at this time, it's what we're talking about for PCORI is not specific to trauma-informed care, but I want to just show every time we ask each of these participating organizations, if this topic is important for them, it won't just be the topic of co-production, it will be the topic of whatever they're studying. And the intent is really just to understand, to show, um, how people view, going back to the concept of like, we have to do things that are relevant. Are we asking relevant questions? If we're doing research that people don't really find, quote, relevant or important, obviously that's problematic. So first of all, showing that it is something that's important to them. In this situation, this is from a convenient sample, so I think it's also inflated in that respect. But we will have mechanisms for that going into PCORI to try and randomize some research naive folks that we've kind of pulled in, and then some folks that have more information that have participated in research before and looking at some differences. We also asked if it was important in general for them to participate in research. Then we asked if it was important for them um, if they were interested in learning how to lead research. And this is where I think it starts to get interesting that 91% of people said some version of yes. And then when we said, have you received training on how to lead research in this institution? More than half of the people said yes. So that kind of got me to questioning, do they understand the question? And if they do, that's a lot. I'm very surprised by that. And what do they mean? So then we started digging in a lot more, to understand, um, you know, also if they felt that their input had ever been used to design the HIV care organization, and more than half said yes. So we really want to understand, excuse me, more specifically what they mean by this. So we came up with different ways of verifying. I guess before I flip to that, I'll just say that we asked it about preferred mediums for actually receiving, actually sharing results, and most people said they wanted it through an email. And then, so these are some of the ways that there are three contextual factors for this co-production model that we're using to try and understand how people are viewing different types of co-production dimensions within these institutions. The first one is on knowledge use environment. So really asking what's the extent to which um, this care institution you feel has applied research or evidence to design the care you receive. So basically, like how much do you think that this organization is using empirical data to design services versus just kind of, you know, naively designing things? And then we asked, like, how did you arrive at this conclusion? And I think the next slide actually say, right here, I say, like, feelings and instincts, what you've observed directly. So we're really trying to dig in to understand multiple levels of kind of checkpoints of like how they're responding to things. And then we also had a follow-up question of like, if you do feel like there's a lot of empirical support being used in this environment to design these approaches of the care you're receiving, can you name some of the ways that you know this to be true? So this is not an exhaustive list. This is just a starting point. We're going to be throwing this back to the network to ask them to come up with different ways as well. And we'll do kind of like a Delphi to get to a different place with this. And we'll also do some focus groups. This is how we'll do the enhancements to the survey via focus groups in the Delphi before we do the survey. The next question was the extent to which you believe that staff at this organization um, the extent to which you have been asked by staff to help design the services. So this is really trying to get at like you as a person with lived experience, how much have you been asked to intentionally and systematically improve the service system here? So this is kind of our way of trying to understand, are they being asked to co-produce things? And again, since we don't want to just use that jargon over and over, this is how we're trying to ask these questions. And the same thing, then we kind of list out the different ways that they may have been engaged, and we ask them to endorse the ways that they have been. So, for example, if they say yes here, but then they say, well, I just think this based on feelings, and then they don't mark any of these, then we know that there's a lot of social desirability bias up here. And then the last one is about capacities for co-production. So this is just looking at the extent to which that they feel that their care organization has actually provided training or support for them to actually understand the research that is being conducted there or the research that has been used to improve their care. And you can see it's the same setup of us trying to dig in to really understand and really just look at the reliability of these responses. And then finally, we talked about different ways that someone might be motivated, like what might motivate you to participate in leading research here. And finally, some of the things that I didn't mention, really going back to this organizational trauma resilience, we'll be looking at concepts like safety, trustworthiness, if they feel it's a collaborative space or their voice matters or they're empowered. Those are kind of the things we're going to start to look at as moderators and mediators of these different levels of co-production. And so far, we found that people, for example, who felt that they're in more safe, stable, and nurturing spaces are more likely to endorse that they have been trained to understand the research. So we don't really know a lot of what these associations mean at this point. So we're going to start to really disentangle those. I mentioned earlier starting to do some geospatial mapping of like where co-production's happening, where people are feeling safer versus less safe in different care environments, and then maybe even starting to look at social network analysis as kind of power shifting within these different spaces. Like, how do people get brought into the research co-production space? And so that over time, we want the power to be, the connections and the power to shift away from academic driven into community driven.